the stem cell transplant can be an option as well. Then there's the CAR T cell therapy, where the T cells are removed from the body of the sick child and then engineered to be able to target the particular cancer cells that the child has. Which are oral and have been used as second line or third line for AML that has not responded well to chemotherapy. Next slide, please. So apart from the chemotherapy and the definitive and the other targeted therapies, we also need antiemetics, because the chemotherapy can make a child vomit. So instead of waiting for the child to vomit, you give the antiemetics prophylactically so the child doesn't vomit and so that they don't become dehydrated and they're able to tolerate the drugs well and tolerate their food well. You may also need nutrition supplements because cancer can cause severe malnutrition, and so it's important to keep to do the anthropometry and make sure that the child is getting the right nutrition supplements. You also need analgesia because cancer is very painful. You need we give usually morphine and opioids like those, and paracetamol. We usually avoid the NSAIDs because sometimes the NSAIDs can cause bleeding, and in leukemia we know the platelets are low, so we avoid the NSAIDs, but we usually give them the opioids and the paracetamol, as well as even non-medical methods of distracting the child, like the music, the play therapy, and all those other things that will make the child be comfortable and able to bear the pain in a way that is not so painful for them. Then you also need to have antimicrobials because the immunity is low. They can get very severe fungal infections. They can get very severe bacterial infections. So you have to have a prophylactic antifungal drugs and antibiotic treatment, especially when their neutrophils are very low. And so it's good to do cultures and sensitivity so that you can know when they are infected, which antimicrobials to give. Because if you don't give them, the child can die of the infection rather than the cancer itself. So we've talked about allopurinol and rasburicase. This is to treat the high uric acid levels. As we have said, you need blood products all the time. You need blood, you need platelets. That's why you need to work very closely with a blood bank to make sure that you have enough of the blood products for these children. And as Dr. Joy Frida had mentioned, you need psychosocial support. It is not easy for the child. It's not easy for the caregiver. It's not easy for the siblings at home. It's a very difficult situation for the whole family. And so psychosocial support is very, very important for the child, the caregivers, and the siblings. So in ALL, and in the Global Hope protocols, we have the NCI risk stratification. This is a way to see which is the most high-risk cancer and which is a more low-risk cancer. And so that the high-risk cancers are treated with more chemotherapy, and the ones that are not very high-risk are treated with less chemotherapy. So if a child has a WBC count of more than 50,000, or the baby is less than 1 year old or more than 10 years old, they are high risk. And so they will need to be treated with more chemotherapy than the standard risk. Next slide, please. Then if the child has T-cell ALL, they are also very high risk. And if after the first month of treatment, that is the first month of induction for ALL, you do the bone marrow and check for the minimal residual disease and find that the median residual disease is more than 0.01, then that means that it's a very high risk and that child can easily relapse. And so you have to give a lot of chemotherapy. You have to use the high risk protocols where you give more chemotherapy that is much stronger because there's a higher risk of recurrence. Next slide, please. So the special considerations in leukemia are like for infantile leukemia. Babies who are less than 1 year are very delicate and they're very sensitive to chemotherapy. So their protocols are a bit different than for those babies who are more than 1 year old. And they're adjusted. Remember that their blood vessels are very delicate. It's not easy to get IV lines for them. And so it's important to use the special protocols for the small infants. Down syndrome children do very well when they're treated for leukemia. They get cured very easily, but they're also very sensitive to the chemotherapy. So when you give the treatment, sometimes they can easily get the side effects of the treatment. And so sometimes there's dose adjustments for children with Down syndrome. Then twins, whenever you have identical twins with leukemia, you need to watch out for the second twin because they can also develop leukemia as well. So even if it's the first one who has presented with symptoms, the other one needs to be checked because many times, especially when they are under 1 year or between 1 year and 2 years, the second twin can also develop a leukemia as well. So it's important to remember that when you're dealing with twins, always remember to check on the second one. Next slide, please. So for AML, the target minimal residual disease is less than 0.1%. It's different from ALL, where our target is less than 0.01%. That is what we want at the end of treatment to make sure that the disease is in remission. Next slide, please. Yeah, so for acute promyelocytic leukemia, which we talked about, the high risk is when the WBC count is more than 10,000. So unlike the other leukemias, the other ordinary AML or the other acute lymphoblastic leukemias, where we talk of 50,000 and above as being high risk, 10,000 is what is high risk for acute promyelocytic leukemia. And so the protocols for those children whose WBC is more than 10,000 is a bit different from those whose are less than 10,000. So you need to remember that as you look at the protocols. Next slide, please. So there's also chronic myeloid leukemia in children. It presents with the splenomegaly and then the very, very high WBC counts. It is usually in 3 phases. There can be chronic phase, then accelerated blast phase, convert even into, from chronic myeloid leukemia, they can even change to an ALL or an AML. So it's very important to be able to deal with these children. We have said that many of them are BCR-ABL positive, and those who are BCR-ABL positive are treated with imatinib. Next slide, please. So this is how the peripheral blood film looks like in CML. So whenever you find a child with a very big spleen and has a high WBC count, and you look at the peripheral blood film and you see all these neutrophils that are immature, then you have a high index of suspicion of CML. Refer the child or the sample to a place where the BCR-ABL can be done. And if it is positive, the child can be put on imatinib and can be cured of their CML. Next slide, please. You can see in the bone marrow, you can see all these immature white blood cells. That is how CML looks like. All these horseshoe-shaped cells all over the place. That's how CML looks like in the bone marrow aspirate on microscopy. Next slide, please. Yes, so BCR-ABL is when the chromosome 9, a small part of it at the end, goes and fixes itself on the chromosome 22. So when they join together, they cause BCR-ABL and they produce those abnormal cells in the CML. And also sometimes those abnormal cells can be produced in some ALLs and AMLs as well. So all the time you suspect a leukemia, it's important to do the BCR-ABL. We know that MTRH are able to do that test, and some of the private laboratories as well. Next slide, please. Yeah, so that is the mutation. This is how it looks like when you do FISH. You see that combination of those 2 chromosomes that are not supposed to be together. And that usually is the cause of CML, as well as some leukemias as well. Next slide, please. So there is a type of leukemia called juvenile myelomonocytic leukemia. Usually the children come with splenomegaly, but when you do the bone marrow aspirate, you find that the blasts are less than 20%. For the other leukemias, the blasts are usually more than 20%. And even despite a high WBC, you find it just remains less than 20%. So when you do the BCR-ABL, you find that it's negative. When you do the HB electrophoresis, you find that their HBF is quite elevated. And usually they're hypersensitive to GM-CSF. And they have mutations in the RAS pathway genes. So JMML, that is juvenile myelomonocytic leukemia, has its special protocols on treatment. Sometimes you may think it is similar to to the CML, and so it's something to look out for. When you see a child meeting this criteria and not meeting the criteria for the other acute leukemias and for chronic myeloid leukemia, then you know that you're dealing with JMML, and you need to treat them with the protocols for JMML. Next slide, please. Next slide. Yeah, so that's all that we had for you. Acute leukemia is very common. Almost every week we diagnose new cases in the peripheral hospitals. Many of them are missed. Many of them are confused with malaria. Many of them are confused with sickle cell and many other things. And so it's important for us to have a higher index of suspicion, work closely with the laboratory teams, work closely with the pathologists, that we may be able to pick this. We urge the NCI to make sure that we are able, that our labs can be equipped with the immunohistochemistry and flow cytometry, so that whenever we are suspicious of the test, we can confirm the diagnosis. And we hope that many of the county referral hospitals, especially those with oncologists and pathologists, can be upgraded into centers that can treat cancer in children, so that we're able to manage children closer to home, that children don't have to migrate to far parts of the country, but they can be treated close to home so that they can get good management. Thank you all for listening, and I know that you'll be able to pick up many of these cases. Thank you.
Thank you so much, Dr. Omedo, for that excellent presentation. Quite clear. It was a very good overview on pediatric leukemias. Just to let you know that we have over 1,400 participants who are logged in online. So clearly there's a lot of interest when it comes to pediatric oncology. Kindly, for those who have joined it later, please put in your questions in the Q&A box. We'll have about 15 minutes to tackle that. So I'd like to just thank the two presenters, Dr. Joy Frida and Dr. Omedo, for excellent presentations. And now to the Q&A, I want to start with a question to Dr. Joy Frida from John from Kilifi. He says that one of the biggest challenges with treatment and associated mortalities in childhood cancers is late diagnosis, partly due to the health system challenges and late presentation. So the question is there a clear referral system in place with accompanying standard operating procedures for the same, especially for facilities in rural-based centers? And two, with the training of clinical officers in oncology, how is the MOH supporting and equipping them to make early detection and diagnosis, especially in the primary health care? So that is to you, Dr. Joy Frida. Are there any SOPs for the referral system pathways?
Yes, Dr. Kathy, thank you for that. Actually, we don't have an SOP, and I think maybe, I know there's the workshop happening in September, and maybe those are some of the things that we need to draft, yeah, an SOP for referral for the children. But yeah, these discussions around this, even something like a handbook that can guide clinicians on what to look out for and what to do, that one is also being worked on. On the issue of training of clinical officers in oncology, apart from these online platforms that we have, which is very useful actually, all the content we got from our experts. So these are materials that have been verified and they've actually been tailor-made for our setting. So that's a good starting point. But there are also other training opportunities. I believe MTRH has a higher diploma. Dr. Kathy, could you know the details? I know there's some higher diploma for clinical officers at MTRH. So yeah, there's some training programs available.
Okay, thank you very much, Dr. Joyfrida. Hope that answers the question. So I'll ask a question to Dr. Almedo. One of the questions is on which nutrition indices do you use when treating children with cancer, especially those with tumors? I guess just generally, what nutrition indices do we use in terms of the nutritional assessment in oncology?
Yeah, thank you for that question. It's true, sometimes it can be confusing in cancer if you're relying only on height and weight Z-score, because sometimes a child may have such a big abdominal tumor that their weight could be very high, but yet they are very severely malnourished. So yes, apart from still doing the height and weight Z-score and the BMI for children above 5 years, the middle upper arm circumference, the mid upper arm circumference, MUAC, becomes very useful, because sometimes the child may have an abnormally high weight because of the tumor, but yet they are malnourished. So the mid upper arm circumference is very, very important. So you need to work comprehensively and in collaboration with your nutritionist team. Remember, cancer is a high metabolic rate. The child may also be nauseous because of the chemotherapy. So you need to sometimes even fix in an NG tube prophylactically. Sometimes the child can have mucositis and mouth sores that they can't feed well. So you may need to fix an NG tube. You may need sometimes parenteral nutrition. And you need to work very closely with the nutritionist to make sure that the child is well catered for and is not doesn't get malnourished during the course of treatment and management.
Yeah, that is quite correct. You know, in oncology, proper nutrition is actually quite crucial to support their overall health of the children, their immune system, and even their recovery. So rather than just the weight and the height Z-score or the BMI, we actually use other parameters. There's the MUAC. We look at we really partner a lot with the nutritionists who will look at the nutrient intake. They'll calculate the calories they require. They'll look at what micronutrients the children require. How is the gastrointestinal function? So is this child able to tolerate oral feeds, or do we convert that to parenteral nutrition? And look at the growth patterns of the children. Are they gaining weight? Are they dropping weight? So you need to track that over time so that it can help identify any growth delays or abnormalities. Yeah, so nutrition is actually quite a big field. It can take another, webinar session when we start to tackle nutrition assessment in oncology, pediatric oncology. But thank you for your question. Next, I'd like to ask Dr. Joyfrida to kindly share with us the platform that you mentioned in your talk, where we can get other resources when it comes to oncology. I think there were a few interested participants wanted to know the app and also the website. Maybe you could just, share that slide once more so that people are able to note that down, or you can just give us the website to be able to access the resources. Thank you. Dr. Joyfrida? I think
so
you're
there's
muted.
There's MSARA.
Yes, Kathy?
Oh, sorry, you are muted. Yes.
Yes.
Kindly continue.
Sorry, please repeat the question.
It was about the app that we can use,
Yes.
get the resources for the oncology resources, plus also the website. Yes.
Yes. Yeah. So the website, is the MOH website. So you can get just the Ministry of Health website. You'll get the documents. The policy documents are there. You'll get the cancer control strategy, the previous one and the current one. Then now for the e-learning platforms, there's the M-Saratani you'll find on Google Play Store, as well as the Virtual Academy, which you can just Google on your laptop. And I believe many people have used the MOH Virtual Academy because it has other content also, not just cancer only. There's also other content on the other conditions, even COVID, there was material there. So it's a popular site. Okay, thank you.
Okay, thank you, Dr. Joy Frida, for that. I hope we've noted the website and the e-learning platform. Yeah, for when you have some time and you want to go through some more resources. So the next question is to Dr. Deborah. The question is on I don't know if I've understood the question quite well. So it is, what are the pediatric checklists for pediatric cancers? If I would rephrase, I think probably the question is if there are any guidelines, for pediatric cancer, or a tool that acts as a guideline just to be able to, systematically assess and manage the care of children with cancer. That's what I'm getting from the question.
All right, maybe we have probably not had a single document with all that, but what I can say is that cancer presents like any other disease. It can present it can affect any part of the body and can have symptoms that are very similar to the ordinary diseases we see from day to day. So the most important thing is to have a high index of suspicion. And when you remember that chart that Dr. Joy Frida showed us, or when you see eye changes, when you see persistent bone pain, when you see headache that can wake the child at night and sometimes associated with vomiting that gets better during the day, when you see paralysis, when you see just anything that is off, and looking at that hemogram that has low platelets, a hemogram with a low HB, the high index of suspicion is what is most important. If there's a swelling somewhere, even a lymph node, have a high index of suspicion. Yes, it can be the ordinary diseases, but it can also be cancer. So it's always important that whenever you see something that is not quite ordinary, whenever you see the eye changes, the eye color changes, don't wait for the disease to become very advanced. It's better to have a high index of suspicion, to refer early, and then even it's better to refer and then be told that it wasn't that, but at least you referred in good time such that early disease can be noticed. So what I would encourage you is that you don't have to be sure that it is cancer, but have the high index of suspicion. When you see something sent to a place where cancer can be ruled out, then that way you'll be able to catch the cancer in good time and it can be diagnosed early enough. Yeah, so many of the county referral hospitals can do FNAs. So whenever you have masses that are suspicious, the FNAs can be done, and sometimes even biopsies can be done. We need immunohistochemistry more available and more affordably, and things like flow cytometry as well, because 50% of tumors of a cancer in children can be diagnosed with flow cytometry. That is the lymphomas and the leukemias. So we need to have these readily available in our county referral hospitals at a minimum or no cost to the patient.
Thank you, Dr. Deborah, for that explanation. I think that should you've really tackled it very well. Perhaps what I could just add is, just like any other child who'd come to you in the clinic, in the hospital, you need to take a history, a medical history, and then do the physical examination. And that's when you realize the early warning signs that Dr. Deborah has just talked about, and also Dr. Joy Frida. And therefore now that guides you on what diagnostic tests you would want to request for. And again, it's based on the type of cancer you're suspecting, okay? Not everyone will require a CT scan or a bone marrow aspirate. It depends on what cancer you're suspecting. Thereafter, once the diagnosis is made, then you would want to either, do a staging or risk stratification so that you can assign like a treatment protocol, okay? Of course, there are aspects of the multidisciplinary team review, because sometimes these children require multidisciplinary teams to come on board and even to prepare the treatment plan together. Of course, there's the supportive care, there's the nutritional assessment that we've talked about, there's educational support just for the child, give information to the child, appropriate information, the child and the family, you know, when it comes to the diagnosis, the treatment, the potential outcomes. There is also the psychosocial support and emotional support, of course, because cancer is quite very frustrating, there's a lot of anxiety behind it and emotions. And then there's the long-term follow-up plan. And also, let's not forget the palliative care part of it. So if you're to look at those as part of the checklist, then I guess that is what you're looking for. But different cancers will have different, the checklist will vary based on what cancer it is. So I think it is 3:30. So unfortunately, we're not able to answer all the questions that are on the Q&A, but we could just have one more round to Dr. Deborah. There was a question about oral thrush. How long can we treat recurring oral thrush in a pediatric cancer patient? So that's to Dr. Deborah. And to Dr. Joy Frida, one more question for you. Are oncology drugs part of the essential drugs, you know, like in the KEMSA? And just as a follow-up, what are some of the essential drugs needed for childhood cancer? That will go to Dr. Deborah. So maybe we can start with Dr. Deborah, then we conclude with Dr. Joy Frida. Thank you.
Yes, so if a child has candidiasis in cancer, we remember that the fungistatic drugs like nystatin may not work very well because the immunity is low. And so it may be useful to use fungicidal drugs that actually kill the fungus, such as like fluconazole. We remember that fungi multiply very slowly. And so the minimum length of treatment should be a minimum of 2 weeks. And sometimes you may even have to go on for a month. Then if they are on heavy antibiotic treatment, maybe for a different infection, there might be a need for probiotics that contain Saccharomyces or other fungi that can help compete with the candida so that it is down. Sometimes you can have invasive fungal infections, and when it is that invasive, you might need the stronger drugs like liposomal amphotericin B for the invasive fungal infections. But you need to work together with your microbiology team to do cultures if possible, and know the sensitivities, and work together with your pharmacy team to find the best way, rational use of the antimicrobials for such a child. Yes, so at least with NHIF, we are able to procure many of the basic chemotherapy drugs. And so it has made a very big difference. So a child who has NHIF and has a diagnosis of cancer, we are able to procure most of the basic drugs for most of the basic protocols for cancer, which is a good step. And we hope that the cover will be enhanced such that even supportive management can be included, and also that we can be able to be helping these children even have transport to go to and from home and to the treatment centers easily without having a big burden and having to stay for long in the hospital, because a lot of these cancers can be treated successfully as outpatient, so that there's no need for prolonged inpatient care. But sometimes when transport is lacking, sometimes we are forced to admit the patient, even when they really don't, because of lack of trust, NCA to be able to support. Hello? Can you hear me? I hope I've answered the question.
Thank you, Dr. Deborah, for that. I'm just waiting on Dr. Joy Frida to answer the question on the essential cancer chemotherapy drugs are part of the essential drugs in the KEMSA essential drugs?
Dr. Kathy, yes, the drugs are part of the Kenya Essential Medicine list. Dr. Kathy, you can hear me?
Yes, we can hear you. Go on.
Yes, yes. You're asking if the drugs for childhood cancer are part of the essential medicine list.
Yes, there was a question.
Yes, they're actually part of the list. Just like what you've mentioned, I think even this one, maybe yourself and Dr. Medo are the best to list some of the drugs that are used. Yeah. Dr. Medo, you had mentioned the doxorubicin.
Yes, we for acute lymphoblastic leukemia, we use if it is high risk, we use doxorubicin, dexamethasone. We have the vincristine, L-asparaginase, and IT methotrexate, and those are that is during the induction time. And then usually the treatment for leukemia, acute lymphoblastic leukemia, takes long. It takes 3 years. And so in every stage after induction, there can be augmented consolidation if it is very high risk. There can be interim maintenance. So each and every stage has a set of drugs that the child is supposed to get in the different stages for 3 years after the diagnosis. And so these drugs, fortunately, we can actually procure with NHIF. The only thing that we have challenges with is diagnostics, because sometimes like we wanted the flow cytometry, we wanted the cytogenetics and all that. If you're not in a hospital that has those, sometimes it is at a cost, and that is usually difficult for our clients. It's also difficult because many of our clients don't have NHIF. In fact, the first time you're diagnosing the cancer, they have never even heard of NHIF in their whole lives. So we really need the UHC initiative to make sure that all needy households are met and they are able to be registered with NHIF so that it is not problematic. The other thing is also referring the child to the centers where diagnosis can be made is also a problem. Sometimes it's difficult for them to even pay their hospital bill and get money for transport for ambulance to another hospital. So those are some of the challenges that really need to be addressed. And then sometimes some of the investigations are not covered, and so it's at an extra cost to them. Some of the antimicrobials that are needed may be out of stock in the government hospitals, and so sometimes the patient is forced to buy, which is not good. So it is a good step that NHIF has made, but there's still a lot more that needs to be done to be able to ensure that we are able to catch these cases and treat them in good time, efficiently, without having to waste so much time, and such that people are not impoverished by the diagnosis.
Thank you, Dr. Omedo, for that. If you search for the KEMSA medicine list for 2019, then you'll be able to go through the document and actually see the antineoplastic agents that are actually under that list. There are quite a number, but this information is available online if you check for it. Thank you for that. So as we conclude, I just want to invite to thank everybody for attending this webinar. We shall have another pediatric oncology session next week. That will be on the 5th of September. That's a Tuesday like today at 2 o'clock to 3:30 p.m. The topic will be brain tumors in childhood by Dr. Magoha. So these pediatric oncology webinars are actually a preamble for our pediatric hematology oncology workshop that is going to be taking place on the 19th to 20th September. That will be a Tuesday and a Wednesday from 8 a.m. to 5 p.m. And as we are all aware, September is a Childhood Cancer Awareness Month. So as Kenyatta National Hospital, we have an annual pediatric oncology workshop every September of the year. So the theme of the workshop will be conquering childhood cancer with early diagnosis and treatment, of which we have actually tackled some of the of that in this session today. So once again, I want to thank Kenyatta National Hospital for providing a platform to reach many health workers in the country, to be able to offer information, to be able to sensitize the health workers on matters pediatric oncology. I'd also want to thank our speakers today, that is Dr. Joy Frida Chepchumba from NCCP, and Dr. Deborah Omedo from Kisii Teaching and Referral Hospital for their excellent talks. And I would also like to thank the participants for joining in and all the questions that have been asked. And we have had quite a great learning this afternoon. So for me, I would like to conclude the session and wish you all a good afternoon. Thank you.
Okay, thank you.
Yes.